Sir, regarding what are your tricks doing a reverse shoulder, do you go by classic deltopectoral approach or?
So you can use a deltopectoral approach or you can use a deltoid split approach, but I go in between the deltopectoral and deltoid split because we don't want to be very medial, we want to be a little lateral. So I would probably to go into an interval which is just lateral to the cephalic plane.
And sir, how much do we need to medialize and distalize it?
For if you see the reverse shoulder, the classic Gramo processes, the initial designs, they were the designs of medialization. So you tend to medialize the humerus and you tend to medialize the glenoid. And these are the designs in which you distalize the shoulder but you don't lateralize it. So initial processes were coming up with an angle, the neck shaft angle of 155 degrees. So nowadays the processes we are doing, mostly Zimmer Biomet processes. So it's an onlay processes and the neck shaft angle is about 135. And these processes will lateralize as well as distalize, but it will distalize less as compared to the Gramo design. So you have a less chances of acromial fractures, acromial stress response and notching. So notching and acromial fractures are more common with medialized designs, medialized humerus design as compared to a lateralized humerus design that is more commonly used nowadays. So nowadays what we are using is either medialized glenoid and lateralized humerus or a lateralized humerus and a lateralized glenoid. Normally that is more recommended nowadays.
So how do we prevent scapular notching in reverse shoulder?
So again, notching is not a complication. So some amount of notching is acceptable.
Yes.
So only the grade 4 notching is pathologic when it evades through the inferior screw.
Yes.
It goes through the inferior screw, that is pathological. Otherwise, it is acceptable. And as I told you, using a more lateralized humeral design is usually safe. Besides that, we tend to inferiorize the glenoid base plate and we need to inferiorize so you use an offset on the glenosphere and tend to use a more, put it on a more inferior aspect. So inferior offset, increasing inferior offset is a technique to decrease the notching, glenoid notching.
So, as the patient for reverse shoulder are mostly osteoporotic, they will come to us at the age of very late age only. So, do you go with the cemented or uncemented?
So, if you are using a regular, if you are doing a reverse shoulder for arthropathy, osteoarthritis or rheumatoid arthritis, most of the cases you will be able to put a proximally coated uncemented prosthesis. The patients in which the proximal portion is worn off, like a fracture case, there is no proximal bone to fit the proximal humerus. So those patients will need to be cemented. So trauma patients and tumor patients in which you have to do a resection of the proximal humerus. So these are the two patients in which you do cementing primarily. Very, very rarely you need to do a cementing in the other group. Like in most of the groups you can do a uncemented option easily because it's a proximal fit and it's a non-weight bearing joint. So usually the proximal fit is good and you will be able to do it. Now there are two designs. The one you have seen is basically an onlay design. The other design with the Stryker one is a Tornier is an inlay design. So you can actually ream the metaphysis and put it into this. So that's an inlay design.
Sir, any experience about stemless and stemmed anatomical total shoulder replacements?
Stemless reverse India mein it is not available. Stemless hemi and stemless total are available, but I have not seen very encouraging results with them. So I am not a proponent of a stemless hemi or a stemless total person. They are not that pain free and the range of motion is not good. The range of motion that will reverse is now. So previously we used to do a lot of anatomical total shoulders.
Yes.
But again the range and the function after anatomical shoulder is much lesser as compared to reverse. So nowadays we are more inclined in doing reverse in most of the arthritic cases as well as trauma cases. So in trauma also, instead of doing a regular hemi, we are inclined in doing a primary reverse as compared to a primary hemi.
So in your personal experience, inlay or onlay, which is a better
for reverse?
Yes, for reverse or maybe
Reverse, for reverse. So humerus actually depends on the technique that you do. So when you do inlay processes, you decrease the tension. So there is lesser chances of any neuropraxias and lesser chances of acromial stress response. If you do an onlay, it will give you a better stability. So there are pros and cons of both of things. If you ask my personal opinion, I am more of an onlay guy. But then if you are using inlay, then you can just follow the principle of inlay and do it. So inlay is more lax, I would say. Onlay is more tight. So with onlay, you have more neuropraxias, more stability. Here you have less neuropraxias, less stability.
Sir, in some cases where the glenoid is too small for a base plate to be put on, how do we tackle that situation?
You need to have a mini base plate. The 25 mm is the smallest base plate that is available, and usually that will suffice. The only thing you will not be able to do in those cases is you will not be able to put the AP screws.
No.
Usually you will be able to put superior inferior screws, but AP and lateral screws you may not have a good purchase if the glenoid is very small. That is okay. So even if you are doing that Tornier design, so it is recommended if you are not putting AP screws, that is okay. You can just put superior inferior screws.
So regarding pseudoparalysis, what is the better for these patients? Like we should go for a arthroscopic repair in rotator cuff.
So pseudoparalysis is basically rotator cuff tear. So I would recommend if the cuff is repairable, repair it for sure, 100%. Repair is much better and plating is much better. Basic concepts. So reverse is only those patients you are not able to repair and you are not able to fix. Otherwise you are not going for a reverse. Reverse is a salvage surgery. It's not a primary surgery. If you are able to do repair, if you are able to fix the fracture nicely, fix it.
So other than the cost availability, cost effectiveness, the bovine collagen that is available, other than use it, what are the indications that you prefer to use?
So Regentem basically is a bovine collagen patch which you can do. You can put over the rotator cuff to repair the rotator, to increase the healing. So it increases the healing, it increases the thickness, final thickness construct of the rotator cuff repairs. So those patients in which you feel that the repair is suboptimal, that is one case. And it is also recommended in those patients in you have a partial rotator cuff tears. You can just not do a repair and just put the patch as it is. So it will increase the healing. And thinned out rotator cuff tear is another indication, in which you have a very thinned rotator cuff tendon. Then you can increase it because it is postulated that if you put a patch, then it will increase the thickness of the rotator cuff by 3 millimeters. And it incorporates with the tendon inside.
Sir, in your techniques, we have shown that we can put a balloon inside the acromion.
So balloon is again a salvage procedure. It's not a primary procedure. So it is going to be launched in India. It is so far not launched, but it is basically indicated for those patients who have an irreparable rotator cuff and the patient is not willing for going into an arthroplasty. Apart from those, I would do a repairs. Most of them.
Sir, in glenohumeral arthritis type B2, where there is a biconcave glenoid and a posteriorly decentered head, how do we prepare the glenoid, sir?
So basically nowadays you have a augment option available.
Yes.
In most of the systems. So even if you are using a Stryker, if you are using a Biomet Zimmer, they have an augment system available. So you can do two things. Ideally, it is recommended that you put your base plate at 0 degree of torsion.
Yes.
So other thing is you can cheat a little bit. So occasionally, if I feel a little bit of posterior wear, I would little bit cheat my placement, and up to 10 degrees I would accept it. So up to 10 degrees, if I am putting my plate, I am okay. This is again debatable as far as the literature is concerned. They will say that you put always in a 0 degree of torsion. But in my personal practice, I would cheat up to 10 degrees. So up to 10 degrees, if you want to do a retroversion and put it, it is okay.
Yes.
If it is more than that, then it is better to use an augmented glenoid. And augmented glenoid again is of two types, half augment or a full augment. And it is recommended to use a half augment. It is better than using a full augment. So the half augment in which, so you have a system in which you can use half augments. So again, that is also 5 and 10 millimeters. So you can use those augments for a type B2 glenoid for this posterior. Again, the downside to this in India is the cost, because the augmented glenoid again becomes little bit more expensive.
So, in distalizing in reverse shoulders, how do we assess this is and adequate distalization so that it doesn't cause neuropathy?
So tension. So there are two techniques that you can see. Once you are done with your preparation, and once you are done with your implantation. I'm talking about the Biomet processes. So the inferior edge of your stem, or basically the brooch, should be at the level of the glenoid.
Okay.
The inferior edge of the brooch and should be at the level of the inferior level of the glenoid. So that is one. Second thing is you can assess the tension of the conjoint tendon first. So once you put your trial, you can assess the tension. It should not be very tight.
Okay.
Otherwise, it will place more stress on the nerves, and it will have a high chance of acromial fractures also. So it should not be very tight. But overall, by and large, I would still like to put the processes in a tight as compared to loose, because the most common immediate complication of reverse shoulder is a dislocation. So it should never be loose. It should be